Okay, so let's pick up where we left off. We were talking about what's going on at the capillary bed. And so as blood is coming into the capillary bed, it's going to, go, whoops, I had that. Sorry, oh my gosh. I could stop the video, but then that would take me another 5 minutes to get it started again. So I'm just going to just hang with me. There we go. All right, technology. All right, so as the blood is coming through the capillary bed and it's moving through that capillary bed, things are going to be moving out and things are going to be moving back in. Okay, think you have to exchange things out of the capillary bed, and you got to get things like waste products back into the capillary so you can carry them through the system. And so there's two forces at work here: hydrostatic pressure and osmotic pressure. So these are the pressures that are at work in the capillary beds. And so hydrostatic pressure pushes things out of the capillary bed, and osmotic pressure sucks things back in. So hydrostatic pushes, osmotic sucks. Hydrostatic pressure is the pressure. Think of it as like blood pressure. It's the pressure of the blood. And so you have a capillary hydrostatic pressure, which is the capillary blood pressure. So remember, if you take your blood pressure, it's 120/80. Well, that's in the aorta and the brachial artery, and as it gets small, as the arteries get smaller and smaller and smaller, that pressure starts to come down. So it's not very high, but there's still pressure, enough pressure to push stuff out. Okay, so it can push fluids out of and through the capillary walls. Okay, and it's greater at the arterial end at the venous end. Okay, so it's going to be able to push things out of the capillary bed. Now, as things are being pushed out, there's going to be a little bit of pressure, not much, but there's some pressure. It's usually assumed to be zero, but it's called the interstitial fluid hydrostatic pressure. And that's the pressure of the interstitial fluid kind of pushing back. It's not much, but to think about this as how it kind of works is if you were underwater blowing up a balloon and the pressure of your air forcing the balloon open, and then maybe the water exerting a pressure on it, not allowing it to get too much bigger. So that's the interstitial fluid hydrostatic pressure. Then you also have osmotic pressure, and there's a capillary osmotic pressure, and there's an interstitial osmotic pressure. And so if you think back to early anatomy, we said water always follows sodium. We said that a lot. Well, we also have what are called plasma proteins. Remember that your cells are semi-permeable, they're selectively permeable, and so there are big proteins in the blood that kind of act like sodium. They cause water to follow the big plasma proteins. So if you have a high concentration of these big plasma proteins, they're going to draw the water back in. So they're going to suck back in. So as fluid is leaving, so here's a vessel, okay, and let's say the blood's coming through, and as the water's leaving, the proteins are staying, so they're going to become more and more and more concentrated as it's moving through the capillary bed. They're going to start to exert a pressure, an osmotic pressure, to suck the fluid back in, okay? The interstitial fluid osmotic pressure is pretty low because there's not a lot of proteins out in the interstitial fluid. So this is what this looks like. Okay, so here comes the blood. It's going down the artery. It's going to split off into the arteriole. And because there's pressure, that's still that blood pressure, that capillary blood pressure, that hydrostatic pressure, it's going to start to push fluid out into the interstitial area. Okay, but you need to reclaim that fluid because you need to fill up your vein on the other side. All right, so that hydrostatic pressure is pushing fluid out. But those plasma proteins are becoming more and more and more concentrated as you move toward the venous side. So they're going to exert an osmotic pressure and draw that fluid back in so that now the fluid level that entered the capillary bed equals the fluid level that exited the capillary bed. And it actually may be a little bit less because some of that fluid is going to be picked up by the lymphatic system and carried through the lymphatic system. I put a little U-bend here. If you don't remember this from 201, you might want to go back and think about semi-permeable membranes and how osmotic pressure works. So in hydrostatic pressure, we're literally pushing the fluid through, okay? So pushing it through. With osmotic pressure, as you are increasing the concentration of the solute, you're making it more concentrated as that fluid is leaving, and it's going to suck it back in. Hope that made sense. So osmotic pressure pulls or sucks the fluid back in on the venous end of the capillary bed. So the exchange is kind of a push-pull between the hydrostatic pressure and the osmotic pressure. But it allows the fluid that comes into the capillary bed to equal the fluid that goes out, so that you don't have a venous system that's dry. You have fluid on the other side. It also, as things are being pushed out, that's taking things out into this interstitial fluid to provide nutrients to the cells in the body. And then their waste products, they're going to be drawn back in as the osmotic pressure is drawing that in, it's pulling things with it. Whew. All right, so venules. It's been a long day. All right, so venules. So arteries become arterioles, arterioles become capillaries, capillaries become venules, venules become veins. So as capillary beds unite, you're going to get these venules. And they're very porous. This is where you allow fluids and white blood cells to get out into tissue. So when you're talking about maybe an infection, you need things to get out into an area and fight off an infection. You need the cells to be able to leave the blood vessels and get out into the tissues and do their job. That's going to happen in the venules. They don't have, they're not as thick-walled as the arterioles. Most of them are just one layer of endothelium. Some of the larger ones may have two, but these little small venules is typically where things can exit out in white blood cells into the tissues. So as venules come together, so as two or more venules come together, they're going to start to make bigger and bigger veins. And so the veins become bigger and bigger and bigger the closer they get to the heart. So you have like small veins in the toe, it becomes a bigger vein in the leg, becomes a bigger vein in the abdomen, becomes the vena cava, and then you have that big large vein going, which is the big large vein going to the heart. They have very thin walls, very large lumens compared to arteries. Again, if you were to look at an actual artery and vein, you can see through the vein. They're thin wall. They don't have very high pressure. The pressure is lower than it is in arteries. So if you cut yourself and the blood's just kind of oozing out, that would be a vein that you've cut. If you cut and it just starts spurting out everywhere, that's an artery. Okay, so the blood pressure, you don't want to do that. The blood pressure is lower in veins than it is in arteries. Has a thin tunica media and a thick tunica externa. They're called capacitance vessels because they are big blood reservoirs. Remember I showed you the pie chart, and most of your blood's in the veins because they do store a lot of our blood. The job of the veins is to make sure you get blood back to the heart, okay? And so a lot of times there are more than one vein than there are arteries. So like in your arm, we're going to learn how to find these arteries and veins. There may be one artery going out to the body, but there may be two veins returning back. You always want to have a backup plan, a second way of blood coming back. So if maybe you've crushed this vein, you can still get blood back to the heart. So there's always one or two or three veins for every artery. Now, if there's no pressure in the vein, okay, so if the heart is pushing the blood out of the arteries and it goes out to the arterioles and out to the capillaries, but the pressure is pretty much zero by the time it gets to the venous side, how does it get back to the heart? We're going to get there. I just want you to think about it. All right. These veins, they offer little resistance, so blood can easily flow through them. But you have something called valves, okay? You have valves in the veins. So if you look at veins, they have little valves because they don't have their own, the heart's not really pushing anymore. And you're thinking about blood kind of coming back up to the heart. Think about being upright. As blood is flowing back to the heart, remember when the heart beats and then relaxes, the blood kind of falls back and that kind of reduces the pressure in the whole system? Well, the blood in the veins would just keep dropping back every time. So you have these little valves that prevents the blood from backflowing. So it kind of goes forward, back, forward, kind of moves like that as it's going through the body because you have these valves. You also have some veins that are called venous sinuses. And they're kind of big flat veins, and we'll talk more about those when we talk about the coronary sinus of the heart. But if I use the word, I want you to know It's kind of a big flattened valve, a big flattened vein. So how do we get the blood back to the heart, okay, if there's no pressure in the venous system? Well, we have what's called a muscular pump, a respiratory pump, and venoconstriction. So the muscular pump, that's your skeletal muscle. As blood flows through the skeletal muscle, those veins are flowing through skeletal muscle, and those muscles are contracting. They literally kind of do like that, and the muscles help to squeeze the blood back to the heart, okay? So it kind of milks that blood back to the heart, and with the valves, it prevents it from falling back or backflowing. Let me show you a picture of that. So this would be the muscular pump, all right? So remember, blood's coming in this direction, and here's my valve, okay? So the heart's beating, the blood's being pushed forward. It's pushing forward. I'm going to change colors. Blue doesn't really show up on the vein, does it? So as the blood's moving forward, and now the heart's relaxing, the blood's going to drop back some, okay? But that valve is going to close and prevent it from falling back. Well, as muscles contract, they actually squeeze on the veins as well, and they kind of start to milk. You know, think about toothpaste. When you get to the end of the toothpaste and you kind of start to milk it to the other end, you kind of squeeze it forward. That's what the muscles do. So that's why they tell you if you're walking, if you're sitting a lot, you need to get up and walk every once in a while, because the blood, if you're not using your muscular pump, that blood will start to kind of pull. Gravity will pull it down, and it won't move up to the heart. So if you're on a long plane ride, you know, your legs may start to swell, your feet may start to swell, may start to ache. You need to get up and walk around so that skeletal muscle can start to move that blood back to your heart. And we'll talk about some clotting issues that can occur if you don't do that as well later on. So the respiratory pump, this works because as you're breathing, so let's look at your thoracic cavity and that big muscle called the diaphragm. So here's your abdominal pelvic cavity below that. Here's the lung, here's the heart. So as that diaphragm is contracting and relaxing, it contracts and relaxes as you breathe. It changes, as it moves, it changes the pressure inside your abdominal cavity. So as you breathe in and breathe out, that's going to change the pressure exerted on your abdominal cavity. So think about if you want to have a bowel movement, you can hold your breath and kind of push. You're increasing the pressure in your abdominal cavity. Well, it's increasing and decreasing all the time with every breath. And those pressure changes kind of act like a, I know that sounds weird, but it kind of sucks the blood up the venous return, for lack of a better way of explaining that. So the pressure changes as you breathe, and those abdominal veins help to kind of move that blood back toward the heart. And you can also have something called venoconstriction, where you can actually constrict the vessels, and that helps to kind of push the blood back to the heart as well. All right, so those three things all work together, and I'm sure we can find something, maybe a nice animation at some point to help demonstrate that. I'll look for that. All right, so the last thing we're going to talk about are some disorders of the blood vessels. We have atherosclerosis and arteriosclerosis, and I'll just be honest, a lot of people just use these interchangeably. Even my husband, we've talked about that. You have to hear both words interchangeably. Technically, atherosclerosis is when plaque builds up in the vessels, and arteriosclerosis is when they actually become thicker and harder, but a lot of times they go hand in hand. These are both going to be due to high cholesterol, different people who have high blood pressure over time, things like that. They're going to lead to plaque buildup and hardening of the arteries. And if the plaque builds up, remember, platelets can get caught on that and cause a clot. If the arteries are hard, they don't respond as well. They're not as elastic as they were, and they don't recoil like they should in responses to blood pressure. So you can have a hard time maintaining your blood pressure. Your blood pressure may go up. You may wind up having a heart attack or a stroke. So those are two common things. Those are the ones we think about a lot of times with people with stroke, heart attack. They have atherosclerosis or arteriosclerosis. An aneurysm is when an artery kind of gets a weakened spot on it in the wall, and it ruptures. It's a blowout. And depending on how large the vessel is that has the aneurysm and where it is, it can be fatal. So think of an aortic aneurysm, that huge artery that's carrying all your blood to your body. an aneurysm there, you're going to bleed out pretty quickly and probably be fatal. A cerebral aneurysm, where you have a blood vessel explode or blow out in your brain, unless they can get to you surgically pretty quickly, that could be fatal. So if they can find them, they will try to fix them. You don't want them to blow out. A stroke is just when a vessel bleeds out, you have a hemorrhage, or it's blocked. So for whatever reason, you've now reduced the amount of blood flow to the brain. So a stroke is in the brain. It's like a heart attack of the brain. So you're having some kind of a hemorrhage or blockage in the brain. The brain needs oxygen, and you're causing brain damage. Varicose veins is when those valves of the veins fail. So those valves, so if you have the blood coming back, and so that somehow they've prolapsed or not working anymore, and the blood just continues to fall back, and the vein will start to kind of swell. And so you'll see these large, knotty-looking veins on the backs of women's legs a lot of times. And that can be because a lot of times during pregnancy, all the baby weight's pushing down on the abdominal pelvic cavity, and so it's kind of impeding the return of the blood from the lower extremities, and the blood's kind of pooling and causing those vessels to stretch out and the valves to fail, so you get varicose veins a lot of times with pregnancy. With old age, the more stationary you are, the more sitting you do, the less the muscular pump is allowed to move that blood back through the veins. The more pressure that those valves are under, the more likely they are to fail. So you need to get moving to try to prevent varicose veins. All right, so that's all I'm going to talk about now. That's long enough, and I will see you in the next video. Thanks again.